So here we are. We are so excited for this live session. I think we're live on Zoom and we're live on Facebook. And we're here with Dr. Robyn Wilhelm. Do you want to do our quick introduction, Laurie?
Yes, well, I'm Lori,
And I'm CJ.
and we are active intimates. We're sisters from Scottsdale, and we make lingerie to love confidently.
We're so excited to be here today with Dr. Robyn Wilhelm, and we'll be introducing her and in just a minute. But this is all about pelvic health, and we're so excited because it's such an important topic, and there's so much to know about it. And I think a lot of women, we don't know the ins and outs of it, and we don't know all about how to take the best care of ourselves in that way. So we have an hour with Dr. Robyn, and it's going to be really interesting and educational.
Yes, and be sure to ask questions if you have them. We'll make sure that we get them answered, or that Dr. Robyn does.
Yes. Great. So I'm going to introduce.
So I guess we'll get started. So we're, as CJ said, so excited to have Dr. Robyn here with us. Dr. Robyn Wilhelm, aka the Mom Doc, is a pelvic physical therapist who specializes in postpartum recovery and core and pelvic health issues. So do you want to tell us a little bit about yourself and your practice, Robyn?
Sure, sure. First of all, thank you so much for having me. I just want to extend some gratitude there. It's awesome when you have people reach out and want to talk about pelvic health and sexual health, because sometimes in our society and communities and stuff, it's still a bit taboo, but there's real issues going on out there and really important things to talk about. So thank you both so much for having me. I really appreciate it.
Welcome.
What I'll do is actually, if it's okay with you, I'll start screen sharing just a bit, because there's just a little bit of info about me on the first part, but then we'll get right into it so that we can have a good discussion and if anybody has questions. So again, I'm really grateful to be talking to you all today. And I know some people may be watching like a replay of this video. If you are watching a replay and you didn't catch us live, feel free to put questions in the comment section. I'm actually a part of the group as well, so I'll make sure I check back tonight after I watch the Kentucky Derby. I'll check back and see if there's any questions, and I can get them answered through the comment section as well. So just a little bit about me. Of course, bear with me just a minute. I went to go, there we go. Technical difficulties for a bit. So I'm really glad that you're here. If you saw that the conversation was on pelvic health, sexual health, postpartum health, and it really interests you, I'm really excited that you decided to join us today. A little bit about myself. I've been a physical therapist for over 17 years. I actually was born and raised in Ohio and moved out to Arizona in 2007. So I've been here quite a while now. Not quite used to the summers yet. You would think I would be by now. But that's okay. There's pros and cons, right, to everything. So I do specialize at this time in pelvic health. I'm a pelvic physical therapist, which just indicates that I've had additional training in core and pelvic health, and then also pelvic exam. So I do that primarily right now. I've also been involved in physical therapy education. So I've been a professor, which I really enjoy because I love to teach. And I love those light bulb moments that you have with students. It's exciting. Right now I run a private clinic, and I kind of have my information there on the slide if anybody would have to, want to get a hold of me. Also, interestingly enough, I didn't put my email up there, but the email is hello@themomdoc.com. So if you have questions that you'd like to ask maybe a little bit more privately, you're more than welcome to email me as well. I do try to stay active on Instagram and Facebook because I do like to share education and awareness about pelvic health, postpartum health, maternal health. So feel free to join me over there. And we have a fun time sharing each other's work, I think, as well. So it's always nice to build up some other people, especially women that are empowering others by having their own businesses and really supporting causes like sustainability and fashion, like you both do. So I think it's awesome. So feel free to come over to Instagram or Facebook and join both of us for that matter. Currently, I do see patients in my clinic and also telehealth. So I had a couple opening thoughts because the conversation on pelvic health could probably last even more than an hour. And we kind of talked about that in preparation for this, is there's so much to talk about. So I just thought some opening thoughts and then me going into a few things regarding pelvic health and then opening up for questions may be a great way to start at least. And these are my thoughts professionally and personally about pelvic health. But pelvic physical therapists should be an option for all women and men too. So I'm really talking a lot about women today, but I always like to point out that men also have pelvic floor musculature, men also have sexual health issues, men also have core issues. So really pelvic physical therapy should be available and known for everyone. Now, of course, it's available, but what we're kind of facing still in the last couple years is that it's just not as known. So I myself work to try to increase awareness. A lot of my pelvic PT colleagues, making sure that doctors know about pelvic PT and what we do. So it should be available for everyone. Pelvic PT can help with sexual health, but the treatment itself is not sexual. I actually just did an Instagram reel about this yesterday, is that sometimes pelvic health, because of the nature of things that we deal with, can be a bit sexualized, but it's really a huge myth about what we do for treatment. So we are trained professionals. Yes, we work in areas that are very private to many people, but we do that in a very professional, holistic manner. So we're also focusing on how your pelvic health or sexual health or core health really is affecting your whole body, or vice versa. Pelvic and sexual health is still a bit taboo, so I kind of just mentioned that. So being that it is taboo, you may not have heard of pelvic PT. Maybe no one's ever mentioned it to you. Maybe there's not a lot of discussion either in your family or your community or your culture or your religion about sexual health, or even about something as early on as menstruation, for girls. Maybe there's a lot of communities where the talk about that is still pretty slim, right? And so we know that as pelvic PT. But we do try to work to educate the community as much as possible. All birthing persons should see pelvic PT after birth. I have a really strong stance on this. This actually occurs in some other countries. For an example, France. In France, when you birth a baby, you automatically have 10 to 12 visits approximately with a pelvic physio, is what we're called over in France and in the UK. And so a pelvic physical therapist is coming in to help the birthing person with recovery, movement, because maybe they've had a vaginal delivery or a cesarean delivery. So there's a lot of education we provide to new moms, even in those early stages. And then also about the 6-week mark, we can then start to do intravaginal exam, check the pelvic floor and core, help them with healing and help them with exercise progression and getting back to the things that they love to do while they were pregnant or maybe before they were pregnant. Pelvic and sexual health not only affects people physically, but also mentally and socially. So even if you pop over on my Instagram page or you pop over to my website, I am primarily talking about physical health and pelvic health, but you'll see a lot of mention of social connections when your pelvic and core health is better, and you'll see a lot on mental health, because I really do view the body holistically. So as a pelvic PT, that's how I treat. So we recognize that maybe a new mom that is home over a year with a new baby and is still having urinary incontinence, which is leakage of pee, for example. If she becomes very conscious about that, conscious of smell, conscious of not being able to go out without always having to wear something or wondering what activity she'll be doing, that can really affect her socially. So even socially, pelvic health conditions can affect you. So that's just one example. Here's a little information about what physical therapists are. Now, this is a really long, drawn-out definition, but again, we are musculoskeletal experts. We are physical therapists, and that's how we train and we graduate as physical therapists. And then if you'd like to be a pelvic PT, there's additional coursework and training. So there's different organizations that provide some of this coursework, and then that really gets your knowledge to an accelerated level on pelvic anatomy, core anatomy, even physiology. You go into kind of the systems of even like the bladder and the reproductive system, and you're looking more at the pathophysiologies that can occur. And then you're also trained to be able to do a pelvic exam. So only pelvic PTs should be doing pelvic exams, which is what you see mainly across the board. But that's just something I always mention so people understand the difference between maybe seeing a physical therapist in like an outpatient orthopedic setting or if they are really looking for one that specifically also has the training in pelvic health and pelvic exam. Pelvic physical therapy is really appropriate for people of all ages. A lot of people don't realize that we actually have pediatric pelvic physical therapists. So interestingly enough, I do not work with pediatrics. However, in my adult population, when I have people fill out the health form that they fill out before they come to see me, I do ask questions about whether or not they've had a history of constipation, a history of bedwetting, a history of any kind of pelvic, bladder, bowel function difficulties from a young age. Because with some of my patients, I do see that some of this stuff started years ago, actually when they were kids or late teens, especially for some of the women I see, maybe some of their difficulty with their menstrual cycle, pelvic pain, really painful periods started when they were, 12, 14, 16. So you may not know that, but yes, we do have pediatric pelvic physical therapists. And then also those that see the adult population like myself, males and females, clear and well into, my goodness, 80s. I've had pelvic PT colleagues that have had 80-year-old women coming in that have pelvic organ prolapse, and they're helping them with that. And so people are still living in their 80s, and their sexual and pelvic health still matter into their 90s even. I don't want to just stop at 80s, but so here are some common symptoms or conditions that you could possibly see a pelvic PT for. I know it looks like a very long list, but I wanted to put down there as many as I could, because sometimes, again, if you're not familiar with pelvic PT, you may look at something and go, oh, I had no idea. So prenatal and postpartum education and treatment. We can help people get ready for labor and delivery. I myself do a bump and birth session, which is prep for labor and delivery, how to use your breath with the pelvic floor to assist you in the second stage of labor. Urinary incontinence, which is urine leakage. So that might be on, a consecutive daily basis. It might only be when you laugh or sneeze or cough. It might be when you try to get on the trampoline with your kids. It can vary. Core weakness, and we'll talk a little bit about the core. Pelvic floor weakness, sometimes known as vaginal laxity. Pelvic pain, pelvic organ prolapse, which is an actual descent of pelvic organs down through the vaginal canal or encroaching into the vaginal canal. Vaginismus. Vaginismus is, there's a little separation I just want to provide here. Dyspareunia, which is on the other side, on the other column. Dyspareunia is painful intercourse. Vaginismus is pain with intercourse, pain with tampon insertion, potential pain and inability to have gynecological exams completed. So it's a little bit of a different level than dyspareunia, but that's the differentiation between the two. Hip, pelvis, and low back pain that hasn't resolved. Sometimes the pelvic floor muscles are involved, and until you have that exam and find out the condition of the pelvic floor, you may not even realize that the pelvic floor is involved at all. Pubic symphysis dysfunction, that's the front there where we connect with the pelvis. You see that a lot in pregnancy, but you can see it after also. Vulvodynia, now this is actually pain associated with the vulva itself, which we're going to just go over some quick, real basic anatomy, and I'll go over that a little bit. Your sacroiliac joint, which is where the back of the pelvis actually comes together, so below the low back. Coccydynia, which is tailbone pain. You're going to see that pelvic floor muscles come clear up and connect to the tailbone. So then you'll maybe be able to kind of visualize and kind of appreciate, like, oh, now I can see why, if there's issues with the pelvic floor muscle, could also be having tailbone pain. Post-op hysterectomy, which is very important. I find that's actually very minimally addressed in the United States from the experiences I've had, which is kind of sad. Women should receive a little bit better education, in my opinion, post-hysterectomy, and also know how the type of surgery that they've had can affect their physical condition and what they can do to help themselves. Pudendal neuralgia. Pudendal nerve is just a nerve that pierces through the pelvis, which gives sensory, so like if you're having pain or if you feel numb, gives sensory input and helps with actual motor input, so the muscles moving and contracting. And then post-pudendal nerve decompression surgery. So this is if somebody is found to have a compression of that pudendal nerve and then they need to go in for surgery. Really important that they're seeing a pelvic PT after. As far as the prenatal and postpartum, some things that are a little bit more specific in there that people don't always realize is anything from pelvic floor to exercise progression to caring for yourself with those aches and pains with breastfeeding and just the new kind of, I call them mom movements, that we tend to do a lot. Once we have kids, we're bending down a lot, we're caring for them. And some people are, during that time period, even healing from a cesarean birth, which is a major abdominal surgery. So that umbrella of care there is huge and quite extensive. So one of the things that that CJ had asked that I just talk about and mention is like, what is a pelvic physical therapy exam exactly? Which I get that a lot. So I have people call in for a discovery session and they'll say, what is this exactly? Or what do you do? I just want to kind of know before I sign up and come in. So for your first visit, what you could expect is very much like a regular physical therapy visit. Okay, so we're going to talk about your history, your medical history, and your current issues. So I'm going to also talk about if you're coming in postpartum, we're going to talk about your birth story as much as you're comfortable with, because I really want to understand how you labored, how long you labored, everything that was involved in that. Then we're going to do a physical exam. So this is one thing I always mention to individuals. We might have somebody coming in, I think Sam's getting those for us. Thank you, Sam. And that is a really awesome picture there. I see. It's a cougar picture there I see on the side. So welcome, come on in. So then we're going to go on to the physical exam, and physical therapists, we do look at the whole body, right? Of course, we're focusing on the issue at hand, but don't forget, even linked into your pelvic health issue that you're having or your core issue, we're going to look at things like your range of motion, your strength in your muscles, your posture. I'm going to talk to you about your daily activities. I'm going to talk to you about your work. What are you doing for work right now? Are you home all day with children that you are attending to and carrying around? So that's all very important. Then we get into the pelvic exam. The pelvic exam is always done with, well, everything is always done with the informed consent of the patient. But I do let people know that if they come to that first visit and they're a little shy about the pelvic exam, we work it at the speed that you need to work it at. It's absolutely fine for people to say, I thought I was ready, but maybe I'm not. And honestly, all of my patients have usually said to me, oh, that was fine. That wasn't as bad as I thought it would be, or they just didn't know what to expect. So with the pelvic exam, we're going to look at not only the vulva area, and we're looking at the skin, we're looking at just the health of the tissue. We're going to look at then vaginally, and then also assess the pelvic floor muscles. And I'm going to just show you a couple of pictures and explain that a little bit, just so you can get a better idea of what we do for the physical exam. All right, perfect. So let's go on with the core anatomy. And again, I'm just showing you this so you can kind of appreciate and get a sense of like, where are all these muscles that pelvic PTs deal with and what do they look at? So for core anatomy, we do have additional training in this. If you can see, you're gonna see my cursor kind of over these pictures here, see it coming around. This is a side view of your body. And right here, what you're seeing is the diaphragm muscle. So the diaphragm muscle, some of the muscles in your deep spine, okay, so kind of coming from the front and then going real deep and back towards the spine, all of your core muscles here that we think of most commonly as abdominals, and then the pelvic floor muscles right here, that is all considered your true core. So we look at that function and we look at how those muscles react even when you're doing something as simple as breathing in and out, because there's pressure regulation here that occurs in the core that can affect your pelvic floor and it can affect your core. So any of those conditions that we talked about, like pelvic organ prolapse, diastasis recti, which is like the continued separation of the midline of the tummy after birth, or with people that are really heavy lifters, sometimes you'll see a separation there. All this can affect actually those conditions as well. So it's really important that we check out your breathing and your core muscles. This right here is actually a picture of vulva anatomy. Now, if you by chance are looking at that and thinking to yourself, okay, I guess I just categorize the whole thing as my vagina, that's very common. It's not uncommon for people to sometimes not catch the differentiation between vulva and vagina, but this is technically your vulva area. So you can see it's more of the external area, right? So you're seeing like the mons pubis, which is the top of your pubic bone. You do have the clitoris here, which is the area of sensation and arousal for women, besides obviously the G-spot as well. The clitoral hood is just tissue that comes up and over the clitoris here. You have the labia itself, so you have outer and inner labia. The urethra is our second opening that comes down, and then you come to the vaginal opening. The perineum is the tissue between the vaginal opening, the bottom of the vulva, really externally, and also the anus. So when I mentioned the word vulvodynia and I mentioned pain or irritation in that area, that diagnosis or that condition is really looking at this part of your body. So maybe there's no irritation or issue inside the vaginal canal or vaginal vault, but you have something going on with sensitivity and irritation in the labia, even up into the mons pubis here where the pubic bone is. So here is actually some really nice depictions of pelvic floor muscles, but let me just kind of explain them from where we're looking. So this right here, this is kind of like we are hovering over the top of a pelvis, okay? And we're looking down into the pelvis. Now, knowing the muscle names and things like that is never that important, right? That's something that pelvic PTs do, and we learn all of that stuff. But what I like about this picture is, can you see the expansion of pelvic floor muscles from the front to the back? So here would be your spine, and also side to side. So you can see that the pelvic floor muscles, sometimes we call them the pelvic bowl, because they literally form a bowl of support for the base of the pelvis. And we also sometimes call it a hammock. We refer to the muscles almost as a hammock. What you're seeing here with the openings is you're seeing the urethra opening here. So the urethra goes and passes through there. You're seeing the vaginal opening here, and then you're seeing the anus here. So what you can appreciate by this picture, without having to know names or anything like that, is just, wow, look at the influence that these muscles can have on these spaces here, the openings. So for example, say this side was pretty tight and that muscle was even more contracted. It could put a little bit of pressure, you know, right there on the anus or the rectum, where the rectum's coming through, could put some pressure on the urethra. So sometimes people present to us with bowel changes, bladder changes, and we do an examination to find out, is the pelvic floor influencing that change? This is a different view. This is as if you were actually, if you can imagine, you were laying on the exam table for maybe a women's wellness visit, or you came in to see a pelvic PT, and this would be you as the practitioner looking directly then at the patient, okay? So what you have here is anus, vaginal opening, urethra, and the clitoris here. Now this picture, what it shows, because it looks like there's a lot involved, is you're just seeing the ligament structures involved here. That's everything in like a lighter blue, which we consider all that too. We consider ligaments and nerves and everything. And then what you're also seeing here is the superficial layer of the pelvic floor as I trace it. There are 3 layers to the pelvic floor muscles. This muscle here is also part of a superficial layer. And then back here, you can't really tell from the depth perception of a picture, but these muscles here are your deeper pelvic floor. So this is into your 3rd layer. What you're seeing here is actually just it's kind of a nice picture, because if I orient you, here's the bladder. And of course it's cut here, so you're not seeing the full thing. Here's the bladder. So here's the ureter coming out. Here's the vaginal opening. So a lot of people don't realize how close all those structures are. I mean, it does seem obvious from the first picture that they're close, but then look at the pelvic floor muscles and how they interact and come around those areas as well. And this is just a small portion of pelvic floor muscles. There's tons here, but they've kind of separated them out for you to see these two. So it's amazing how the pelvic floor can actually interact with all of those structures. Doing an internal exam of the pelvic floor, which is what I get asked about the most, if they're asking about the evaluation process. This picture is nice because what it's showing is, as a clinician, I have a gloved hand, obviously, just using one finger. I go through the vaginal opening, and you can see kind of the shaded out part here where it illustrates how by maneuvering around in the vaginal opening, I can feel the first layer of the pelvic floor muscles go back a little further. You can feel 2nd layer structures back just a little further, and you can feel 3rd layer. So this is what it looks like in a pictorial view, which is sometimes helpful for individuals that then realize, like, oh, is that how they can actually feel the pelvic floor muscles? So what I want to do, I'll pause just a second in case I've missed any questions, but then I'm going to go on and just talk a little bit about a couple different pieces of pelvic PT, some things that we see that I get a lot of questions on, just to kind of educate you on some of those things if maybe you're unsure, you don't know, and then we'll open it up for questions as well. But is there anything that I missed so far in chats or on Facebook or anything?
Don't think we have anything here in chat. Sam, do we have anything on Facebook?
No, not just yet.
Okay, perfect. So the first thing I'd like to mention is perineal tears. Now this occurs during birth, vaginal delivery. It's not uncommon for women to have a perineal tear, but what I do find in practice is sometimes it's common for women to come in and we'll be talking about this, and I may say, what stage of perineal tear did you have or what grade? And oftentimes they don't know. So in the moment of childbirth and in the moment of knowing that you've had a tear and the doctor is stitching and helping that situation, it's pretty understandable that even if the doctor said and mentioned a grade, it may not be remembered at that time, right? There's a lot going on, but I would like to see women a little bit more informed, even after, maybe as the doctor comes back in or checks in on them before they're discharged, to let them know what kind of tear they had, and then also that a referral to a pelvic physical therapist would be helpful for additional healing and what to do with it. So tears can happen obviously during childbirth. What you're seeing here in this picture is you don't have to pay as much attention to the information over to the right-hand side, but if you follow the cursor, what you're seeing here, this is demonstrating a first-degree tear. Often tears do happen towards the lateral or the side because of the way that the baby comes down through the birth canal and comes out. It often pushes to one side or the other. So when you're seeing a first-degree tear, you're getting a tissue tear here. Often there's no muscle involved, which is good. Sometimes for a first-degree tear, they will actually stitch a little bit, or sometimes they'll wait. They'll determine how much swelling is going to occur, and then they'll determine whether or not it can heal on its own, or they'll do like 1 to 2 stitches. The second-degree tear, which you're seeing right here, is now going to start involving some pelvic floor musculature. So what you see shaded off behind here is that pelvic floor, those pelvic floor muscles that we talked about. You're seeing the superficial ones, and you're seeing this muscle here, which is going to be affected potentially. And then also these muscles come around the anus here, and they're all connected. This is also pelvic floor here. So you'll notice as you get to a 3rd-degree tear, and even a 4th-degree tear, now you're getting into what we call the anal sphincter, which is the muscles around the anus. So that's where you sometimes may see or experience, if you've had a 3rd-degree or 4th-degree tear yourself, you may experience difficulty holding in gas. You may experience fecal incontinence, which is a leakage of poo out the anus itself. And it's because the control of the pelvic floor muscles, especially in the anal sphincter, have been lost in their healing. Okay, doesn't mean that has to last forever, but those tissues need to heal first, and then you need to work on strengthening or see at what state those tissues are. So that's where pelvic PT comes into play. If someone has had an episiotomy, this is a surgical cut, and it is through the epithelium, and it is through the transverse perineal muscle, which is this muscle here that comes across the perineum. And then also the bulbocavernosus. Name's not important, but I will point this muscle out to you. This is the muscle that comes up and it goes right along the labia here. And again, it's deeper, right? So what we're not seeing here is all of our skin tissue and everything, but that muscle is also cut a little bit. So episiotomy, even women who have had episiotomies really should be seen by a pelvic PT after birth as well. Pelvic floor tension. So oftentimes people will say, what are kind of the major things that can go on with the pelvic floor? And usually the focus is on either tension, so too much tension in the pelvic floor, or its weakness. So just to provide a little bit of information on that, some symptoms of pelvic floor tension can include what I have listed here. So constipation, painful intercourse, pelvic pain, an inability to empty your bladder completely, or even painful urination. Pelvic floor tension means that the muscles are actually a bit more tense than they should be. So they're under a state of contraction. Keep in mind that pelvic floor muscles are what we call tonal muscles. They always have tone. A lot of our muscles in our body are always carrying tone, right? But if you think of the neck muscles and you think how those muscles really have to sustain tone to keep our head upright, think about the same thing with the pelvic floor. The pelvic floor muscles keep a certain amount of tone to support pelvic floor organs, to help with hip mobility and also hip stability. So it's okay to have tone in the pelvic floor. That's not a bad thing. But if that tone is too much, then you're going to see it doesn't relax to allow you to urinate easily. Maybe during intercourse and during penetration, the muscles really fight a stretch, and that can be painful. So again, these are just some symptoms. They're not all of them, but they may indicate that somebody is experiencing pelvic floor tension. I have a little blip of information there, is that oftentimes if someone is experiencing pelvic floor tension, they can also experience weakness. So they could be saying, I don't feel like I can empty my bladder completely, but then I get up and I'm doing things and I leak. And so it's very frustrating to them, right? So pelvic floor muscles can be tight and also weak. And in those cases, if somebody were at home and they thought, well, if I'm leaking, I probably need to do some Kegels, I need to strengthen my pelvic floor, it's really a good thought. It's a very well intended thought. However, with some people, if that tightness is there, they can do Kegels all day long and they'll probably get frustrated because they won't see a lot of progress with their leaking. And the reason is because oftentimes if pelvic floor tension is there, you need to actually work on lengthening those pelvic floor muscles, releasing some of that tension before you can actually start to strengthen. Okay, so our pelvic floor muscles need to move in a range, just like our neck muscles do, just like our bicep muscles do. So if my bicep was really tight and I thought it was weak as well, I wouldn't just work it in this range all the time and then hope to strengthen it. I really need to work on making sure it works through the whole range first. Then I can really throw in contraction and strengthening principles at that point. So what about pelvic floor weakness? So how might that look, or what kind of symptoms may someone have? Some symptoms, again, not an exhaustive list, but some, is urinary incontinence, so leakage, urinary urgency or frequency. So really difficulty controlling that sense of like, I have to go to the bathroom now. Oh, I have to go again. Oh, I have to go again. Sometimes that occurs when the pelvic floor is lax, and so the ureter is a little bit more lax as well. Stool or gas incontinence, so not being able to kind of hold in if you want to pass wind. Pelvic organ prolapse, oftentimes this first presents as feeling like a pelvic heaviness or a heaviness through the vagina. So if you look at the picture off to the side, this is a side view, and right here you see the pelvic muscles going from the front, the pubic bone, all the way back to the back, the tailbone. And then you see again how all those structures really go through, they travel through those pelvic floor muscles, right? This is the vaginal vault here, the vagina, and the uterus is up here. So if you have a laxity of pelvic floor muscles that are here and around here, it sometimes doesn't support keeping everything up as well, okay? So you may find that the uterus starts to slip down the vaginal canal. The rectum will even sometimes start to push forward and kind of encroach into that vaginal space. Or the bladder itself can even actually descend a bit and encroach into that vaginal tissue a little bit. So there's a couple different types of pelvic organ prolapse, but that's the idea of what's occurring if you have pelvic floor weakness. Sexual dysfunction can also be an issue. Pelvic floor laxity can lead to not feeling things as well during intercourse. That can be both for the man and for the woman, a sense of looseness to where it's not as pleasurable. And then pelvic girdle pain. So don't forget that the pelvic floor muscles, they really help to stabilize the hips as well. They work alongside the hips and the glute muscles. They all work together. So if you have one of those areas that are weak, you could start to feel like, I feel really unstable in my pelvis. And I notice I'm getting like a lot of pain in the sacrum, which is just right above the tailbone. Or gosh, I feel like when I walk, I feel like I'm made with pins and needles and some of them are loose, you know. I hear that a lot from women who are pregnant and the laxity is kind of taking place. They say they feel a little wonky, you know, when they're walking, they don't feel supported. Urinary incontinence, just a little bit about this because unfortunately it's so common. It affects about 1 in 3 women. Only 25% of those women approximately will seek help though. It has kind of, due to many different reasons, products on the market that you can simply wear or put in if you're experiencing leakage. The kind of taboo of talking about it, trying to kind of hide it, all of those reasons have culminated into women not necessarily seeking help for it. And also it's often been discussed in such a way that it's kind of like, well, you've had babies, so what do you know, that's just kind of the way life goes, or you're postmenopausal, so you have lower estrogen, probably some, vaginal laxity, so you're gonna pee now. Kind of the jokes and little snickers we've made, even our grandmothers may have said, don't make me laugh, I'm going to pee my pants, or, it's just become so common in a sense to talk about it, but in a little bit of a joking way if it is talked about. So all of those products and things like that are available on the market, they do certainly have their place for some people, right? Because when you're working on trying to improve your continence, for example, with pelvic PT, you still need some of those things, right? But we try to be really careful about the predatory kind of fear mongering marketing that occurs with some of those products that make it sound like urinary incontinence is just inevitably what every woman will experience, in their late life. So there's a couple different kinds there that I just listed. Stress incontinence is when you laugh, cough, sneeze, jump, and you leak. Urge incontinence is when you're constantly like, I got to go to the bathroom, and you just can't get there in time. It's almost also referred to as like an overactive bladder. And then also mixed, so people can have both. But it is very treatable. And of course, that differs for everyone. And the amount of pelvic PT work they need to do may differ as well. One thing also I wanted to mention is this refers to postpartum. And I talked about this last weekend when I was presenting for the 4th trimester AZ conference. What happens postpartum at that 6-week checkup? So for anybody out there that's had children, whether or not you have newborns at home or your kids are grown and out of the house, oftentimes there's big emphasis on that 6-week visit. And in this particular talk last weekend, we were talking a lot about intimacy after birth. So this is kind of where that's coming from. But I like to let moms know, new moms, even people that see me into their 40s and say, I've been leaking for a while, I've been having not so comfortable intercourse for a while, and it's finally time I seek help. I kind of take them back and I remind them at that 6-week visit, that is really just a time that your midwife or your OBGYN is checking the vulva and vaginal tissue for healing. Okay. If you've had a tear, if you had an episiotomy, if you had a lot of swelling after birth, they're just looking and checking. Everything healing okay? Does everything look good? Is there any reason why I would tell this mama to not do exercise, not have sex, anything like that? And oftentimes, thankfully for many women, the answer is, you got the green light, you're ready to go. But I get so many mamas that come in and go, what does that mean? Well, what am I supposed to, what exactly does that mean? And quite frankly, I have some women that come in and say, I was ready to have intercourse at 4 weeks, but I waited, just to make sure. And I have lots of mamas that come in and say, the doctor told me at 6 weeks I was good to go. And I almost was trying to decide if I was going to tell my husband that the doctor said that I was good to go because they were not ready. They just couldn't imagine intercourse at that time. So we're all a little different. The healing's different. But minimum 4 weeks for healing from a vaginal delivery. A cesarean, you're looking more at 6 weeks. It's a major abdominal surgery. That is really a very tried and true good recommendation, to be honest with you. The tissue heals in the body anywhere from a 4 to 6 week period before you can really put added extra stress on it without a greater risk of injuring the tissue. So in the 6-week visit, they're just going to tell you if they feel like the tissue is healed, right? Healed adequately up to that 6-week mark. And they're also in many cases going to be talking about contraception, which obviously is a personal choice for everyone, but that's kind of the main 2 things they're focusing on. So what I'd like to tell people, what are some of your yellow light situations? So situations in which if you feel like you're not ready for intercourse, don't beat yourself up about it because it's really normal not to be ready. Things like if you had the episiotomy, perineal tears. I mean, imagine, we talked about those briefly. Imagine those 3rd and 4th degree tears. That's some healing time. And then, if you haven't been seen by a pelvic PT, the tissue can be tight. It can be painful. there's some other work that needs to be done maybe before you can go into intercourse feeling more comfortable. And then if you had a delivery with forceps or a vacuum, that automatically puts people at an increased risk for pelvic floor dysfunction. Doesn't mean it's a guarantee, but it's something that you want to clear yourself of, get checked out by a pelvic PT, make sure everything's okay. So if you feel like, gosh, I was not ready at 6 weeks, or I'm 4 weeks, if you're listening, and I'm not ready, absolutely normal. And pelvic PTs are really your primary individuals, primary docs to help you through that phase of your physical healing. Same thing with post-cesarean birth. I always like to mention that April was Cesarean Birth Awareness Month. And I like to remember to tell moms, all moms, but especially cesarean birth moms, that we carried a baby for approximately 9 months, plus or minus. And so we still put all of that weight and all of the stretch and the pressure down through the pelvic floor. So whether or not baby came out vaginally or baby came out cesarean through the tent or through the top of the roof, like some people like to say, it still impacts your pelvic floor health. Okay, so you still deserve care, and it's still something that you want to consider after birth is pelvic PT. Kegels, I want to mention, excuse me, I want to mention Kegels because they've grown in popularity. There's more awareness about it on the internet, social media, which all in all is actually a great thing, right? We're getting these things talked about a little bit more, which they should be. Pelvic floor contractions, or Kegels, is when you're actually working the pelvic floor. You're doing a contraction. Keep in mind that it's not always about just the contraction. We're also wanting to see that full range, right, of muscle movement, like we talked about before. So I'm focusing on the contraction. I test this during the pelvic exam, but I'm also detecting how well can the person relax their pelvic floor. I work with soon-to-be moms on this. We work on this for labor and delivery prep. And then obviously Kegels, a lot of people are using them for initial connection. And we're addressing that to see if they're actually, like, how connected are they to their pelvic floor, right? Are they breathing appropriately when they're doing Kegels? A big myth about Kegel is that every woman should be doing them. Now, is it a great idea to keep up on pelvic floor contractions? I would say yes, on a general basis. But again, like I discussed earlier, if you are someone that may have pelvic floor tension, you may actually either do a little bit more harm or just not get anywhere with your goals if you're just doing Kegels. So having a thorough pelvic exam by a pelvic PT can help you establish and know, is my pelvic floor tight? Is it fine as far as tone, but it's just really weak? So I need to start working on those. And then a big thing too with Kegels is that pelvic PTs are going to turn them into functional things that you're doing. And we're going to talk to you about the breathing and the pressure management when you're doing Kegels. And then we're going to get you out of the position of maybe just doing them on the bed, and also talk about when you can do them around the house when you're doing things or during exercises. So we take that Kegel to a whole nother level, which a lot of people need, but they just don't realize they always need it. So those are a couple of the topics that I feel like I talk about maybe the most or get questions about. But again, I would love to hear any questions you have. And again, if you're watching this as a re-recording, then please feel free to put comments in the section below, or even email me at hello@themomdoc.com.
That's great. We do have a couple of questions on
Great.
Facebook.
So we have a couple questions from Ashlyn. Do you have any stretches or movements you'd recommend we do at home to strengthen those pelvic floor muscles?
Yeah, so, that's a great question. I do get that sometimes. Obviously, it's often based on, once I see somebody, we do a thorough pelvic exam, we find out what's going on, then you're going to get the best prescription and guidance for strengthening, for stretching, things like that. But in general, when I talk about stretching, even on Instagram or Facebook or in chats like this, one of a really nice stretch that you can do for the pelvic floor is, it's a yoga position, and we use it as a pelvic floor stretch as well. It's called the happy baby. This is where you're actually laying on your back. You bring your knees up towards really your face, but then bring them out and towards your shoulders. So you're getting a nice big stretch in through the pelvic floor area, the perineum. If you think about a baby when they lay on their back and they start discovering their feet, and they're really happy and they're playing and they pull their feet up to their face and they have wonderful flexibility for the most part. That's a happy baby stretch. Okay. So a lot of people that may do it in yoga don't always realize that they're actually doing a nice stretch for the pelvic floor, but some do. It just depends on if your yoga instructor talks about that or not. Keep in mind though, when you do that stretch, I always tell people try to hold stretches for at least 20 to 30 seconds. Breathing in and out with your stretching, so you're not holding tension anywhere else in the body. And then also the happy baby position, you may feel a little stretch around your perineum or like the vulva, vaginal opening a little bit, those superficial layers and muscles. You won't feel the stretch as obviously in the deeper part of your pelvic floor, but because the position that you're in with the legs spread and the pelvis spread a bit and then the knees up and at an angle, you are getting a nice stretch throughout. So hold the stretch, breathe through it, and it'll help with the pelvic floor.
The other question we have is, are pelvic PTs usually covered by insurance?
That's a great question as well. I get that a lot too. So, and I always, regardless of if somebody ends up coming to me or not, I love to make sure I talk to patients if they need to about the insurance, because I myself, for example, am cash-based practice. Now, a lot of pelvic PTs in the Valley will be cash-based. A couple reasons for that, and I'll make it short. And I'll speak just for myself. Insurance coverage sometimes is not so great for PT, and also sometimes they're a little not so great with pelvic PT, which is a frustration of mine, but that's a whole different soapbox that I won't get onto. But when I see patients for a exam, I see patients for an hour and 15 to an hour and 30 minutes. So it's a decent amount of time. When I see people for follow-up treatments, it's a full hour one-on-one with me. And this often then helps for women to only have to usually come in once a week to see me, versus maybe in a busier clinic or outpatient clinic where they have a pelvic PT on staff. Sometimes they have to, because of the way that they get reimbursed and the poor reimbursement rates, they do have to stack patients a little bit differently. And again, that happens. So I'm not really passing judgment on that. I've worked as a PT for a long time. I've worked in those clinics. But what that creates sometimes is feeling like you only have a good 30 minutes with your patient, right? So I may need to see you in that setting 2 to 3 times a week. So I tell people, for one, always check with your insurance. If you know that the PT that you want to go to, pelvic PT, is not not linked up to insurance, so we're considered out of network, call your insurance company and say, what are my out of network physical therapy benefits? Because that is the benefit coverage that you'll get. Sometimes it's 80-20, 70-30, they change it up depending on your insurance. If you're kind of really drawn to a certain pelvic PT and they are cash-based and you think, oh, I'm not sure if my insurance will cover. If for some reason you call and they're like, well, if it's out of network, we don't cover it all. I have some patients that use their HSA or FSA, and they're fine with that because it's for their health and maintenance, and they want to get things checked out. So that's always an option. But in general, most of my patients, I would at least say 60% that have seen me, I give them a super bill and they submit that bill, which is basically a receipt, but it has a lot of info that the insurance companies want to see. They submit that and they do get reimbursement. The reimbursement may be a little less than if I was in network. I can't speak to that because all the insurances are just a tad different. But yes, overall, you should have coverage. And even if you want to see a cash-based PT, you may have ways to get that covered, either out of network coverage or using your HSA, FSA.
Awesome. Thank you so much.
Yeah.
I actually have a question.
Yeah.
So when would you recommend seeing a pelvic physical therapist versus a gynecologist?
Oh, that's a good question. So one thing I'll preface my answer with is that in most states in the United States, you do not have to have a physician referral to see a pelvic PT. We're considered direct access physicians. I use the term physician a little lightly. We're doctors of physical therapy, not doctors of medicine or osteopathic practice, but you don't always have to have a referral. So we are trained through things like red flag symptoms, when they should, when somebody should be referred back to their OBGYN or gynecologist. So you could always seek, advice first from a pelvic PT. for the most part, if it's something like, I'll give you a few examples. Like I've had some people come in and they're experiencing some pelvic pain and issues with intercourse, and they came to see me, but they're also seeing their gynecologist. And some of the symptoms kind of linked into that, like they were having odd vaginal discharge, they were having, you know, their menstruation and menstrual cycles were kind of getting wonky. Those are also good things that check with your gynecologist, right? I'm a really big advocate of gynecology care and midwife care. I love it when the gynecologists are aware of pelvic PT and they can say, look, I can help you with these things. I can run these tests. Let's see what's going on. But also in the meantime, this pelvic pain you're having or pain with intercourse, a pelvic PT would really be best to help you with that, right? But when you're talking about a lot of the conditions and the diagnoses and the pathophysiology, checking in with your gynecologist or your midwife is a really good idea.
Awesome. Thank you so much.
Yeah, you're welcome. Nice to see your face, Sam. I didn't see you on camera.
Yeah, I realized maybe I should turn my camera.
That's okay. It's all right.
That's all we have, I think, for audience or viewer questions.
I have a question.
Yeah.
So all the information has been really helpful, and going through the anatomy was really, that was just so educational. A question I have is around prolapse. So if you see someone, either they come in, they think they have that, or you find that through the exam, then what are some of the steps that are taken for that? And is that something they could stay with you or a physical therapist, or they would have to go in to see maybe their gynecologist?
Yeah, that's a great question. For pelvic organ prolapse, they are graded as well. So there's certain grades depending on the amount of prolapse that you're actually seeing. So for an example, I do have many women, especially after postpartum, but throughout years of their life, they'll come in and start to report and say, I kind of feel a heaviness, or after I run, then I feel heavy, but then after I sleep or rest, it resolves, so they're kind of borderline, not quite sure. And maybe they haven't yet been to a gynecologist for any kind of check or diagnosis. Pelvic PTs always screen for pelvic organ prolapse. We are not permitted to diagnose. We are permitted to screen for it, and we are permitted to treat for it. So if somebody is really wanting a true diagnosis and kind of the testing that's done to get to that diagnosis, one of the best physicians you can go to is a urogynecologist. Now, the reason I say urogynecologist versus gynecologist is a couple of reasons. One, let me say that you can go to either. So a gynecologist is also trained at the diagnoses part. Urogynecologists see this on a near weekly basis. I mean, urogynecologists are the ones that are doing a lot of the surgery for prolapse and that kind of thing. So really, it may be for you or a specific person, it may be more about, let me do a little research and see, like, does my gynecologist see a lot of people with prolapse, or I know them and I've been going to them for years, so I can maybe call up the nurse and say, I think I might have a prolapse. What do you think? Most gynecologists will definitely be comfortable to diagnose for it and things like that. Some midwives also. But depending on the severity of it, some people may need to go to a urogynecologist for that. And I do get a lot of referrals from urogynecologists for people to come into pelvic PT once they've been diagnosed. So I just kind of put that out there because it's good to know options and good to know like what healthcare providers do what. With pelvic PT, it's been shown in research, and anecdotally, I've seen this in my practice, that pelvic organ prolapse is graded from about a 1 to a 3, 2.5 to 2 to 3, are served really, really well by pelvic physical therapy, often not needing any type of invasive type of surgeries or anything. It gets a little harder when you go to grade 3, and definitely when you go to grade 4. I wish I could say, oh, pelvic PT can help every grade 4 prolapse, but we're just not seeing that clinically and in the research. Do some people have some great gains and then they decide if they really want to do a surgery? Absolutely, right? Because even if a surgery is recommended to someone by a urogynecologist, it may be in that person's choice for whatever reason that they just really don't want to do it. And so they're trying to do any kind of non-invasive treatment that they can to see how much along they can help that. So pelvic PT is an option across the board. It's just more successful with grades 1 and 2, maybe heading into like that 3 range. Once you actually start pelvic PT for prolapse, a lot of it has to do with that initial exam where we find out what is all going on here. Do you have pelvic floor weakness? How do you manage your pressure, like your breathing? I talked about that just briefly, because if they're exercising a lot, or what do they do for their job, that kind of thing. We talk about everything from even toileting habits, because you don't realize sometimes until you have symptoms of pelvic organ prolapse, that you're then more conscious about, I don't want to push when I'm, you shouldn't be pushing. You try to make sure that you avoid constipation at all costs, so there's so many little bits of information about what you can do in your daily activities to help yourself. But then we're also focusing on how can we try to maybe improve this prolapse. A part of prolapse that's also present there is laxity in tissues and things that are helping to suspend some of these organs, like for example, the uterus. So there are things that pelvic PT can help with that as well. We focus a lot, obviously, on the muscles and the pressure management system. So if you're evaluated by a urogynecologist pretty thoroughly, they oftentimes may be able to identify, what do we have here? Do we have a ligament, laxity that's quite severe? What's going on? And then they can adjunct that into pelvic PT.
That's very helpful. Thank you. And I think I've
Yeah.
seen in some of your posts that it's really quite common, maybe more than we think.
Yeah, more than you think. And it's interesting because they've even done a few, I think it was one major research study that I read, that many women, and honestly can't remember the percentage. I would say it was at least like up around the 30s to 40%. Many of us may be walking around with what would be considered a grade 1 prolapse, but we can be totally asymptomatic. So that's always interesting in medicine, right? I don't know if you've ever, I've read studies even and heard of studies where they do an MRI on, 100 people, right? Only 50 of those people actually were saying they have low back pain or kind of demonstrating some kind of symptomology. But then when they did MRIs on all 100, even some of the people that were totally asymptomatic had like bulging discs on a grade 1 level, or our bodies are just amazing, and depending on how everything else is affected, you could have a grade 1 prolapse and never have symptoms. And it's nothing, and I don't say that so that everyone's like, oh my gosh, am I walking around with a grade 1 prolapse, like should I be rushing off to my urogynecologist? No, not necessarily. But even if you think, or you wonder, or you're at the age where you're like, I've had multiple children, I've never, besides my wellness visits at the gynecologist, I don't have any idea if like my pelvic floor is weak, or I don't know. I have more and more women coming in, which I think is awesome, just for one visit. I mean, if they need some kind of treatment or a home program, I may see them for an additional visit to get that set up. But they're just like, I don't have any glaring symptoms right now, but I've had like 4 kids, 3 kids, I breastfed, everything. And I really don't know, and I'm still really active. So I'd like to get an idea. So that's really awesome. But yeah, it's a little bit more common than what we realize. Nothing to be fearful about and like run to the gynecologist, but just to keep in mind, as women especially, it's all part of our health as we age. So as we're worrying about our wrinkles, which I am understanding now as I get into perimenopause, and we're worrying about, extra skin here or there, we got to not forget about, everything going on below the belt, so to speak, as well.
Yes, really important, because I think we do tend to sometimes forget, or just, not think about it. We think about it.
And it's not talked about a lot, basically. I mean, I think the conversations are opening up, and I think sometimes, even women are surprised at the conversations that young mothers are having with like their young daughters and stuff, like in a good way though, like, oh wow, we didn't ever talk about that with my mother, stuff like that. So the conversations are getting better, but we still kind of tend to forget it just because it's not, and usually we're kind of dreading that yearly exam and stuff sometimes, right? So we just like forget about it until it's like, oh, it's time to go get that wellness check again.
Well, we're really big on getting the word out, and we just hate the thought of women suffering in silence. But
Yeah.
you've given us all a lot to be hopeful about. One of the big takeaways for me was that it's not inevitable to experience urinary incontinence as you age.
Yeah.
It's not inevitable, and you don't necessarily have to take a pill.
Right. And you don't have to, it may feel to many women like it's inevitable, especially if they've had children or surgeries and everything. They may feel like, well, eventually I'll probably notice that I'm leaking. And that might be the case, but knowing that you have options at that time that happens, besides just like buying the pads or buy, whatever. And again, some people, it's really preference, right? There's kind of no shame either way. You have to be careful. I tried to be careful anyway when I talk about incontinence, not to make it too like shameful, as in if you're putting up with it and you haven't seen a pelvic PT, like how could you not? I try not to do that, but we still need to make sure that the voices are loud to the women, that even in the back of their mind, and maybe they're not saying outwardly like, I really don't want to have to deal with this, like why should I don't like this. Letting them know that they have options is really important to me. And it kind of touches even into the point I made about it socially affects people, physically affects people, and sexually, even in intimacy, it can affect a lot of people.
Yes, it's just so important, and I think this has just been a really good education and information around this whole topic. And I know we could keep going, and I know
Yeah.
we'd have a lot more questions, but
Mm-hmm.
you've shared an hour with us, and it went by so fast.
I know. We talked about that before. It does go by fast.
I learned a lot.
Did do. Sam, any other questions coming in before we wrap up?
No, I think we're all set on questions.
Okay, great. Well, Dr. Robyn, thank you so much for joining us on this live today. I think it went pretty well. This is our first time doing Zoom and Facebook Live, so we had a couple little things in there, little glitches, but all in all, I think it went well, and we were just so happy to have you today. And I think, as you were saying, hopefully we'll get people watching afterwards, and we can watch the comments and questions to come in and get those answered for people as well.
Yeah, most definitely. Please leave questions, whatever people are comfortable with. I think you guys have a very respectful group, so I think we're all women and all understanding that it's part of our health. So it's not taboo to ask or talk about. But thank you so much for having me on. Thank you, Sam, for catching questions and helping with a couple of the blips there. But that happens. That's what happens when you're on the internet streets. You never know what's going to occur.
That's right.
Yeah, for sure.
Well, thank you everybody for joining us, and thank you again, Dr. Robyn.
Thank you.
And I hope everybody has a wonderful May 1st. Happy May.
Happy May.
And we will sign off now and see you all soon.